This presentation is entitled Approach to the Patient with Abnormal Liver Tests, Part 1. I have no financial relationships related to the subject matter of this program. The learning objectives of this presentation are listed here. This talk will be provided in two parts. In Part 1, we will discuss the markers of liver injury and liver function tests. We will understand the initial diagnostic approach to the patient with elevated serum transaminases, and understand the initial diagnostic approach to the patient with elevated serum alkaline phosphatase. The markers of liver injury are divided into two classifications. Those markers of hepatocellular injury include alanine aminotransferase, abbreviated ALT, also abbreviated SGPT, and aspartate aminotransferase, abbreviated AST and SGOT. With respect to the specificity, alanine aminotransferase, or ALT, is more liver-specific, with AST located not only in the liver, but also in particular in muscle. The markers of cholestatic injury are four. The most commonly used is alkaline phosphatase. This is found not only in liver, but also in bone, placenta, and intestine. So secondary markers of cholestatic injury are frequently used, and these include gamma-glutamyl transpeptidase, 5' nucleotidase, and serum leucine aminopeptidase. Some general comment about the serum aminotransferases. The levels of elevation carry little prognostic value and correlate poorly with the degree of liver cell necrosis. The highest elevations in serum aminotransferases are observed in drug-associated ischemic or viral hepatitis, with levels greater than 1,000 typical. Occasionally, levels are greater than 1,000 in autoimmune hepatitis and in Wilson's disease. Of particular note, levels less than 300 are common in alcoholic liver disease, where we also see in AST the ALT ratio greater than 2:1. This slide lists the initial diagnostic evaluation of a patient with elevated serum transaminases. Anti-nuclear and anti-smooth muscle antibodies should be obtained to rule in or rule out autoimmune hepatitis. Iron and TIBC, or total iron binding capacity, and serum ferritin should be obtained to rule in or rule out the diagnosis of hemochromatosis. If the serum ferritin is greater than 1,000, HFE genotyping to make the diagnosis of hemochromatosis may be indicated, as it will be discussed in later talks. Antibody to hepatitis C virus should be obtained, and if positive, RNA for hepatitis C virus should be obtained to confirm the diagnosis of chronic hepatitis C. 15% of patients will clear their acute hepatitis C, so they will be antibody positive, but hepatitis C virus RNA negative. Hepatitis B surface antigen should be obtained to rule in chronic hepatitis B, and you should also consider obtaining hepatitis B viral DNA in a patient with suspected chronic hepatitis B. A serum protein electrophoresis, abbreviated SPEP, should be obtained in the serologic evaluation of the patient with elevated serum transaminases, not only to get an idea of the presence of chronic inflammation, but also to potentially rule in the diagnosis of alpha-1 antitrypsin deficiency, since the alpha-1 globulin peak in the serum protein electrophoresis is largely made up of alpha-1 antitrypsin. One could also consider obtaining a alpha-1 antitrypsin level. To exclude Wilson's disease, albeit rare, a serum ceruloplasmin should be obtained, and a confirmatory test in patients with a high likelihood of Wilson's disease should be obtained by evaluating a urinary 24-hour collection for copper. Increasingly, celiac disease can cause elevated serum transaminases, and the incidence of celiac disease is increasing worldwide. So endomyocele and tissue transglutaminase antibodies should be obtained. Although not listed, since there is no serologic evaluation for non-alcoholic fatty liver disease, an ultrasound could be obtained in a patient with elevated serum transaminases to look for fatty infiltration. In contrast, patients with elevated serum alkaline phosphatase, the serologic evaluation is relatively limited. An anti-mitochondrial antibody to rule out the diagnosis of primary biliary cirrhosis could be obtained, but more importantly, abdominal imaging, either with an ultrasound or a CAT scan with and without contrast, should be considered. General rules about an elevated serum alkaline phosphatase are that it is disproportionately elevated compared to the serum bilirubin in patients with partial extrahepatic obstruction, multifocal intrahepatic lesions, and lesions involving intralobular bile ducts. So let's turn our attention from markers of liver injury to true liver function tests. And these are the three: prothrombin time, also measured as an INR, albumin, and bilirubin. Of the three, the INR is probably the most important liver function test, particularly given its very short half-life. It provides a dynamic snapshot of liver function. In addition, albumin, although an important liver function test, can also be reduced in patients without liver disease. For example, in patients with a nephrotic syndrome and protein loss through the urine, protein-losing enteropathy, and loss of protein through the stool, poor PO intake or malnutrition resulting in low albumin, and various systemic inflammatory states in which albumin is low, largely because of extrahepatic signals to the liver to decrease albumin synthesis. Bilirubin is a marker of defective excretory function by the liver, and extrahepatic causes of elevated bilirubin need to be considered. In addition, it's important to recognize that elevated bilirubin may be due to unconjugated or indirect hyperbilirubinemia. The causes of unconjugated hyperbilirubinemia are listed in this slide, and they include hemolysis, ineffective erythropoiesis, with thalassemia being a good example, resorption of a large hematoma in a patient with trauma, pulmonary embolism with infarction. In the pediatric population, Crigler-Najjar syndrome, Gilbert syndrome, and a disorder known as shunt hyperbilirubinemia, in which, as a result of either surgical or spontaneous portosystemic shunts, first-pass metabolism of unconjugated bilirubin is decreased. In February 2002, the MELD score, or Model for End-Stage Liver Disease, was adopted by the United Network of Organ Sharing as an evidence-based means of organ allocation. But this scoring system is also very useful in determining the prognosis and severity of liver function in all patients with liver disease. The MELD score is a severity score that's predictive of mortality, and it includes total serum bilirubin, the INR, and the serum creatinine in a logarithmic equation listed here. This can be calculated by accessing various websites to calculate a score. An example of a MELD score is demonstrated in this slide, in which the patient has a creatinine of 1.9, a bilirubin of 4.2, and an INR of 1.2. This calculates to a MELD score of 20, and using a scoring system like this allows one to predict, for both hospitalized patients as well as outpatients, 3-month survival. In the example we provided, the MELD score of 20 to 29 is equivalent to a 76% 3-month mortality. This slide just demonstrates the plot of the MELD score versus 3-month mortality. Moving from laboratory abnormalities to history taking, I would just like to focus on some important historical points in the approach to the patient with our abnormal liver chemistries. A family history is very important. There are 3 autosomal recessive disorders to consider in patients with chronic liver disease, including hemochromatosis, alpha-1 antitrypsin deficiency, and Wilson's disease. In addition, there is familial clustering of primary sclerosing cholangitis, primary biliary cirrhosis, and autoimmune hepatitis. A medical history is also very important to the approach to the patient with abnormal liver chemistries. Ulcerative colitis puts patients at risk for the development of primary sclerosing cholangitis. 70% of patients with primary sclerosing cholangitis have underlying ulcerative colitis, and approximately 7% of patients with ulcerative colitis will eventually develop primary sclerosing cholangitis. Congestive heart failure is a major cause for abnormal liver chemistries. Diabetes, likewise. Celiac disease, as mentioned previously, and then hyperlipidemia, hypertension, hypothyroidism, obstructive sleep apnea, along with the diabetes, puts patients at risk for non-alcoholic fatty liver disease in addition to underlying obesity as part of the metabolic syndrome. A occupational history may be important in the approach to the patient with abnormal liver chemistries, particularly the exposure to organic solvents, particularly in the automotive industry. These agents have been associated with both acute and chronic liver disease. The exposure history may be important in the approach. Hepatitis A is a common infection, although not associated with chronic liver disease. Daycare workers exposed to children in daycare may be at higher risk for the development of hepatitis A, in addition to the well-known foodborne epidemics of hepatitis A. Hepatitis B, both sexually and intravenous drug use, transmission needs to be considered. Hepatitis C, particularly in the Vietnam-era veteran population, is a common finding. And travelers returning from the Indian subcontinent, possibly even now from Mexico, may be at risk for the development of acute hepatitis E. A drug history is a very important part of the approach. This includes not only a careful prescription medication drug history, but over-the-counter use, including the use of nutritional supplements such as high doses of vitamin A that have been associated with chronic liver disease. But most importantly, the use of herbal remedies. Herbal hepatotoxicity is increasing in incidence and should be considered carefully, particularly because patients don't automatically self-report the use of herbal remedies. There are certain patterns that have been described in patients with drug-associated liver injury. Hepatocellular injury is defined as a ALT to alkaline phosphatase ratio greater than or equal to 5. Examples include isoniazid and the statins. Cholestatic injury, where the ALT to alkaline phosphatase ratio is less than or equal to 2, with examples being androgenic anabolic steroids, erythromycin, captopril, and trimethoprim sulfamethoxazole. A mixed injury covers most other drugs with an ALT to alkaline phosphatase ratio between 2 and 5. Granulomatous changes as a result of drug use have been described and are defined by just an isolated alkaline phosphatase elevation, and examples include allopurinol, diltiazem, and carbamazepine. Physical exam may be completely normal in patients with abnormal liver chemistries, but physical findings to look for include stigmata of chronic liver disease, such as spider angiomas, pulmonary edema, Dupuytren's contractures, scleral icterus, hepatomegaly, which may suggest either congestive hepatopathy or an infiltrative process, and certain skin findings, xanthomas and xanthelasmas in patients with primary biliary cirrhosis, lichen planus in patients with primary biliary cirrhosis, ichthyosis in patients with hemochromatosis, porphyria cutanea tarda in patients with underlying chronic hepatitis C, and finally, the presence of Kaiser-Fleischer rings should be diagnostic in patients with Wilson's disease with extrahepatic involvement. So the next part of this presentation that will be presented at a later time will specifically talk about the approach to the patients whose serologic evaluation suggests underlying disorders that have been briefly mentioned today.